Hi, I'm Isabelle Lange, and I'm presenting on behalf of my co-authors at the LSHTM and at CERUD in Benin about women's perceptions of Benin's free C-section policy. And before the policy came into place, a C-section, women would be expected to pay about 100,000 CFA for a C-section, which is about 110 pounds. And just to put that in perspective, a school teacher might earn 30 pounds per month, a housekeeper 10 pounds a month, so these are really catastrophic costs for families. But then in 2009, a policy was introduced that gave a lump sum, that reimbursed a lump sum to hospitals for each C-section. And this didn't necessarily represent the real cost of the C-sections in each setting. So some hospitals were able to profit from this policy and some were at a loss. And this policy is one of many similar initiatives addressing user fees in maternal health in the region. They started in a wave in the 2000s as part of efforts to reach the MDGs in the critical moment, and hope to improve, to increase facility-based deliveries and alleviate the financial burdens of care on delivering women. So we wanted to understand women's experiences of care, their perceptions of care in maternity wards now that a large financial barrier was removed. How did they experience care and C-sections? So as part of FemHealth, which was a larger interdisciplinary evaluation of these policies in 4 countries, we undertook a qualitative study that consisted of participant observation and in-depth interviews. We started in 5 hospitals, interviewing 30 women who had C-sections, and then moved to 2 case study sites where we conducted a further 30 interviews with women, but this time with women where the care had been observed night and day. We had informal discussions with health workers about their care to really understand, to be able to triangulate the sources of information. And as mentioned earlier, we understood quality of care to be made up of both the provision of care and also the experience of care. So, what did we find? Just a few highlights are that women still feared C-sections. They were not a preferred method of giving birth. But health workers found that it was now easier after the policy to carry them out. There were less delays for them, and they didn't have to have this worry about putting a financial burden on families when they prescribed a C-section. There were blurred lines of consent. Many women weren't informed about their procedure before they were going to have a C-section. And all of this led to C-sections being perceived as a threat by many women, especially in certain settings. That said, though, the costs were more manageable now without this. There were still many bribes and informal payments that remained, and that created a lack of trust for some women with the health center. So what we saw was that even with the removal of the financial burden, the social signification of a C-section means that there's still largely an undesired medical act. And so this should be considered, and the potential for over-medicalization, when developing policies that are also meant to increase access to facilities for labor. Just as these dynamics of obtaining consent should also be looked at when you remove this barrier, and this time to collect money should also be addressed at the maternity ward. And if you go to the poster, I have more information on the 2 different contexts, the case study sites, where you can really see that context and leadership play important roles in how the policy is implemented, and including in terms of the perverse effects such as informal payments and diagnosing the need for a C-section. Thank you.